Good. We're going to move right on to Noah Smith from NHTSA.
Good morning. Pleasure to be here with you all. Be up in a minute. Again, my name is Noah Smith. I'm with the National Highway Traffic Safety Administration's Office of Emergency Medical Services. I serve as the project manager for something called NEMSIS, or the National EMS Information System. I've been asked to spend a couple minutes with you this morning to talk a little bit about NEMSIS and its relationship and opportunities to sudden cardiac arrest surveillance, and of course the context of recommendation number 1 from this report. So what is NEMSIS? Really good question. And I bet a lot of people have different answers in this room, but here's my definition. NEMSIS is an information system whose goal is to improve care through the standardization, aggregation, and utilization of point-of-care EMS data at local, state, and national levels. That sounds really good. That's great. Hopefully it sounds really good. It's a little more complicated in practice. That system has many components in order to achieve that goal, and I'll put a few of them up on the screen for you right now. But I think in the context of this morning's discussion, the two most important are that NEMSIS encompasses a documentation standard by which most every EMT and paramedic across the country use to collect information on most every patient that they encounter every single day. And that data and that information moves from a local database to a state database, and from a state database to a national database, what we call the National EMS Database, which we house at our office at NHTSA. So the two most important components would be the standard and the database itself. NEMSIS has gone through a variety of different versions and iterations over the years. I just want to highlight that we're in the middle of a transition to what we call version 3 of NEMSIS. The version 3 standard, which has been in development for about the last half decade and is being implemented by states this year and next year, allows us to really talk not so much about data collection, but about data utilization, which is what we really want to be talking about. It allows for near real-time submission of data from ambulances on the ground to the National EMS Database. The standard itself is Health Level 7 compliant, which is very important so that it gives us the opportunity to have our data talk to other types of healthcare data in a standard way. And the national and state databases encompass many more data elements than they used to, and that allows for more extensive public research. The database, the National EMS Database, like I said, is populated from the ground up. And this is a map that shows participation of states in the National EMS Database in NEMSIS from version 2. The version 3 map looks a little different than this because we're still implementing, but I thought version 2 looked pretty good, so I put it up on the screen. The 2015 database will be published in just a week or two, actually. And from our version 2 data set, we're going to be publishing 27 million records from 48 states and territories and nearly 10,000 EMS agencies. We think this accounts for about 79% of every 911 EMS activation in the country. The version 3 database includes just 125,000 records from 8 states and 40 agencies. Again, we're in implementation right now. All of this fully available for free for you at nemsis.org today. So you're going to get in a handout as a participant of this meeting a list of data elements that are germane to this discussion about cardiac arrest, but I wanted to put up on the screen, if you can read that, the version 3 data elements that are specific to cardiac arrest, and you will see some very clear, hopefully Utstein compliant criteria listed in these data elements. And these were developed in partnership with CARES and many others so that hopefully we're collecting the same data that everyone else wants to be collecting and we aren't duplicating efforts. These are all the data elements just about a cardiac arrest. If there's a cardiac arrest, it triggers all these data elements. Anything with a red N next to it means that the National EMS Database gets it. Anything with a yellow S is for states, and O is optional. So just like Rob, we've been asked to talk about some of our perceived barriers to cardiac arrest surveillance and then what we would do with $10 million to fix it. It's important to note that we do not have $10 million. So these are some of my perceived barriers to cardiac arrest surveillance. The first, and this is not unique to cardiac arrest or to registries or to NEMSIS or to EMS or to in-hospital emergency care at all, this is about healthcare data, and that is that I believe we have a challenge in our industry when it comes to healthcare data, that there is a lack of perception or perhaps real lack of return on investment when it comes to health IT investment. That is from the perspective of data users and data providers. And I have seen health IT initiatives begin and evolve without always considering the perspective of what I call data entry clerks, but what others might call EMTs and paramedics in this case. And they're left thinking or wondering whether the extra time and the extra effort is actually worth it. And so if we aren't making that connection real, from data collection to improvement on a very local level, these efforts will fail. Our second barrier that I wanted to discuss is how, when we talk about registries in particular, that isn't always in the context of other HIT initiatives and new technology that's coming out, which I think allows for a lot of opportunity to perhaps throw the old model of registries out the window and think new, right, about how we can pull the data that we want, the information that we want, from EMS, from in-hospital, from post-discharge and otherwise, about sudden cardiac arrest patients, from health information exchanges and other trusted HIT infrastructures, as opposed to setting up new registries. I think, lastly, a barrier, and this, Rob touched on this as well, is while we have a goal to improve care, right, or to enhance outcomes or save lives, that might not be good enough for people to act. It's probably good enough for the people in this room to act, but just as Jim was saying, it's probably not good enough to convince a community to act. And so we need to be thinking about and agree upon meaningful, incremental goals that we can all get behind. And I challenge the breakout sessions to think about what the incremental steps are that we can try to achieve together. So then we had a little fun. With $10 million, what would we do? My first recommendation would be to work with the most progressive, well-informed, and well-established statewide health information exchange and pilot test a sudden cardiac arrest registry composed of information exclusively from that health information exchange. This would be a proof of concept that would show a return on investment to all data users, including the patients. We would use the data to develop and benchmark performance measures across the spectrum, and we would use the EMS Compass process to do that. That's a project funded by our office to establish performance measures in emergency medical services. Secondly, these are not mutually exclusive. I would set standards and certify EMS and hospital software packages together to collect, exchange, and submit standard information on sudden cardiac arrest. And I would tie that to meaningful use. And thirdly, if we're truly looking for a census of sudden cardiac arrest, then I would follow the success of other censuses that we have in this country, including the fatality analysis reporting system run by NHTSA. FARS pays a FARS analyst in every state to exist for the sole purpose of populating the fatality analysis reporting system. We can do that with $10 million for sudden cardiac arrest. I am a minute over time, and I just want to say, again, thank you very much, and that there is incredible opportunity, I think, to build off of the standard that exists already in emergency medical services and to collaborate with in-hospital and other partners to make surveillance very real, as long as we're sort of building on the success that many others have had in the past. So thank you very much.
Thank you, Noah.